So it is with great pleasure to introduce my friend, my colleague, Dr. Christina Ha. She's an associate professor and comes from Cedars Medical Center to the snow and the cold of the Midwest. Welcome, Dr. Ha.
I love being introduced with Coldplay. And so thank you so much, Anita, for inviting me to come out here, and congratulations again for your beautiful IBD Center and for everything you've done for Ohio State and the surrounding community. It's very, very impressive. I'd like to acknowledge my colleague and very good friend, Florian Reeder. He is the guru of stricturing Crohn's disease management, and he provided a lot of the slides. These are my disclosures. So I think we've actually talked about this a good deal already during this conference, but really, the time to intervene when we're talking about Crohn's disease is earlier in the disease course, because that's when the majority of the patients present with an inflammatory disease behavior. Only about 10% of patients present with stricturing disease at the time of diagnosis, and just under 20% present with penetrating disease. However, with the increased duration of disease, the likelihood of those curves shifting more towards stricturing and penetrating disease is greater. So by 10 years, close to a third of the patients will have stricturing disease behavior, and close to 40% will have penetrating disease behavior. So you have to keep in mind that stricturing and penetrating disease is less likely to be responsive to the therapies that we have rather than inflammatory behaviors. So as of today, we don't have accurate predictors for intestinal fibrosis. There's not a serologic panel. There's no genetics that accurately predict the likelihood of developing fibrostenotic disease. And we oftentimes identify this based on colonoscopy when we see a non-traversable stricture or certain features on imaging. And this is important to know because we know from the natural history of Crohn's disease that by about 10 years, 50% of our patients will require some form of surgery. And the curve does plateau out around after 30 years of diagnosis to be around 60% of our patients. But because we know that surgery is likely for about half of our patients, we do want to intervene early. This is an excerpt from one of the classic textbooks in inflammatory bowel disease that was edited by one of my old mentors, Ted Bayless, as well as Steve Hanauer. And I'd like to point out an important sentence within this scenario. So they said, no known medication can either heal a fistula proximal to an obstructing stricture or relieve the chronic obstructive manifestations of fibrostenotic strictures themselves. Such cases present absolute indications for surgery. So we're doing our patients a disservice when they have a fibrostenotic stricture, particularly with some complications proximal to the stricture, by trying to optimize medical therapy. You're fighting a losing battle. However, postoperatively, or if they have an inflammatory component, it's a very different scenario. So this is how we should present it to our patients. So how do we differentiate the inflammatory versus the fibrotic components of strictures? Because most have actually a dual component, and it's which one is really driving most of the inflammatory behaviors versus fibrotic. So on imaging, you're going to see three common features of a stricture. First is you're going to see wall thickening around the area of the stricture itself. Then you're going to see some narrowing of the luminal diameter. And obviously, the more narrow, the more likely you are to have some form of obstructive symptoms. But what differentiates a fibrotic component from a predominantly inflammatory component is the pre-stenotic dilation. So if you see a dilated loop of bowel proximal to the stricture, that automatically should signal to you that there's chronicity there, particularly if there's an air fluid level or fecalus, stool balls that are present there, because that indicates chronic stasis. So this may be a patient who's not the best candidate for medical therapy and should be referred to your friendly surgeons like Dr. Ramsey. On an MR enterography, which is the table on your right, there are two key features that differentiate inflammatory strictures from fibrotic, and that's really delayed enhancement or layered enhancement. If you see that on your MR enterography report, and I would actually encourage all of you to have a sit down with one of your radiologists to learn actually how to look at some of these MR enterography images, because sometimes knowing this helps you counsel your patients as to what the right strategy is. But the rest of the features can be present in both. So this is data that actually answers a question from our earlier session about which strictures are most likely to respond to some form of medical therapy. So this is data from what's called the Crohn study, which is a prospective study using anti-TNFs to treat patients with symptomatic Crohn's disease strictures, either ileal or ileocecal valve strictures. And the group found that there were certain factors that were associated with a higher likelihood of success with medical therapy. And those factors include being on immunosuppressive therapy prior to the start of anti-TNFs, having a Crohn's disease obstructive score of greater than or equal to 4. So what is this score? It was a composite score that was actually created by the authors of this study, and it was based on a scale of 0 to 6, based on severity of abdominal pain. So the more significant or severe abdominal pain you had, the higher your score. The presence of nausea or vomiting, whether or not you were hospitalized, and whether or not you required dietary modifications. So interestingly, it goes against what you would think. The higher your score, the more likely you are to respond to therapy. The lower your score, the less likely you are to respond to therapy. Other factors were the duration of their obstructive symptoms, being shorter duration, less than 5 weeks, having a shorter length of the stricture, less than 12 centimeters, and not having sizable pre-stenotic dilation, so the maximum dilation being around 18 to 29 millimeters or less, marked enhancement on the delayed T1-weighted sequences that you see on MR enterography, and no penetrating or perforating complications, such as the presence of a fistula. So to talk a little bit more about this Crohn study, which is probably the best data that we have to support the medication use for symptomatic strictures, this included about 97 patients who were symptomatic but not fully obstructed. So they didn't have severe nausea, vomiting, severe weight loss, but they were experiencing intermittent obstructive symptoms. None of them were treated with anti-TNFs. A good percentage of them had a prior history of surgery, and all of them had a baseline MR enterography and another MR enterography at week 24. And their endpoint was actually a pretty stringent endpoint. They all received induction and maintenance adalimumab, and by week 24, in order to be considered a success, they had to remain on adalimumab therapy without any adverse effects. They did not require endoscopic dilation or surgery during that 24-week period of time, and they also did not require a course of steroids. So what they found was that by week 24, almost 2/3 of the patients with these symptomatic strictures actually achieved this success. 30% actually had prolonged success rate at 4 years, and 50% were able to avoid surgery at 4 years. So there are certain subsets of patients who may actually benefit from medical therapy. And for those patients who do benefit from medical therapy, it doesn't mean that you can't periodically, especially if they have symptoms that break through, perform an endoscopic dilation. So what are the indications for endoscopic dilation? First of all, they should have a symptomatic ileal or ileocecal valve stricture. And you can also do it for isolated anastomotic strictures. You can also perform an endoscopic balloon dilation for some of the proximal bowel strictures, such as pyloric stenoses or at the duodenum. However, those can be a little bit more technically challenging and associated with greater complications. An ulcerated or inflamed stenosis is not an absolute contraindication. However, you may want to take pause and look at your cross-sectional imaging prior to doing it. Now, colonic Crohn's disease stricture is not an absolute contraindication, and it doesn't carry the same malignancy rate as an ulcerative colitis stricture. However, it's not 0. So about 4% of these strictures can harbor dysplasia or malignancy. So you want to take pause before you dilate these strictures. So cross-sectional imaging prior to doing your stricture dilation is important to exclude penetrating complications, to get a sense of the stricture length, and to make sure it's straight and not angulated, because you certainly don't want to dilate an angulated stricture. So what is the success of endoscopic balloon dilation? This is a systematic review of over close to 1,500 patients who went through over 3,200 dilations. And technical success, meaning that they were able to open up the stricture and pass the scope, was about 90%. Clinical efficacy, meaning that there was symptom improvement, was about 80%, and the complication rate was about 3%. So as you're quoting risks and likelihood of success to your patients, this is a great study to reference. What were some of the features that are associated with lack of success? Well, we know that shorter strictures, less than 5 centimeters, were associated with the best surgery-free outcome. But for each 1 centimeter increase in the size of the stricture, there was an 8% increase in the possibility of needing surgery. Duodenal strictures probably had the highest risk for needing surgery. Active disease, however, was not associated with an increased risk, and what they found was that there was insufficient evidence to support intralesional injections of steroids following your endoscopic balloon dilation. So some people may argue that anastomotic strictures are more likely to be successful compared to primary ileal or ileocecal valve strictures. This is a study that was published in 2013, and they looked at patients who had 169 strictures. And really the key findings here were that there were really no differences in the likelihood of needing another dilation or surgery if it was a primary stricture versus an anastomotic stricture. What they found is in the overall population, about a third of the patients required surgery in about 3 years, but there was no differences in who needed surgery versus primary versus anastomotic, and there were no differences in the use of biologics or immunomodulators. But sometimes we do want to recommend treatment after we do an endoscopic dilation. So this is a great study looking at the impact of escalation of therapy following dilation of anastomotic strictures. So this looked at 54 patients who underwent 150 dilations for anastomotic Crohn's disease strictures. And these are patients who had long-standing disease, about 28 years of disease, and they were about 52 years of age. You have to keep in mind these were short strictures on average, about 2 centimeters. Most of the patients had active disease. Over 90% had active disease following the dilation, but it tended to be I2 disease. And of those patients, only about 40% escalated medical therapy. And what they found was the only factor that was associated with an increased interval or a decreased likelihood for need for repeated dilations was the use of combination therapy after doing an anastomotic stricture dilation. And that, whereas if they saw Rutgert's I4 disease, meaning if they saw deep ulcerations or large ulcerations proximal to the anastomotic stricture after dilation, that was actually associated with a 4 times increased risk of needing surgical resection. So the thesis from this is, after you do an anastomotic dilation, if you see disease activity, optimize their therapy, probably with combination therapy. But if you see severe disease, I4 disease with large or deep ulcers, they may be better served, since they've already strictured at the anastomosis, from seeing your friendly colorectal surgery colleagues first with aggressive postoperative treatment afterwards. I think we're all very familiar with the endoscopic balloon dilation technique, but the key thing is size matters, so you want to choose the right size balloon relative to the stricture. You want to make sure, remember that the balloon, the endoscopic balloon dilator, is about 8 centimeters, so you really want to make sure your stricture is positioned right in the middle of that balloon length. You don't want to pull as you're doing your dilation, so you want to make sure your scope is nice and steady, and you will hold at each side for about 60-second intervals. There's, similarly to no increased benefit for using intralesional steroids, there's no incremental benefit of using intralesional or intrastricture anti-TNFs. I kind of want to breeze through some of these techniques because they are not ready for prime time. They've only been reported in case series or observational data, and from our personal experiences, we have not seen a lot of benefit to using endoluminal stents. They tend to migrate, they tend to get clogged either with food or with stool, or there can be mucosal overgrowth that makes it very challenging to remove. I think the best experience with needle knife stricturotomies is with our colleague Dr. Bo Shen, who was at the Cleveland Clinic and is now at Columbia. But you have to keep in mind that these were very short strictures, only 1.5 centimeters median stricture length. Most of the patients required greater than 1 procedure, and the complication rate was about 3-fold higher than with endoscopic balloon dilations, so about 10% complications, mostly bleeding. Contraindications to endoscopic treatment are presence of penetrating or perforating complications, or obviously if there's dysplasia or malignancy. Long segment strictures defined as being longer than 5 centimeters, and if they're technically unfeasible because of angulation or position. My image got in the way of the last one, but it was serial dilation. So what I mean by that is if the person needs to be dilated every 3 to 6 months, you have to ask yourself, what's your end result here? Is this sustainable versus sending them to your colorectal surgeon, getting a good, healthy primary anastomosis, and then assertive postoperative therapy? So with stricturing disease, there really are 3 options. 2 of those involve your colorectal surgery colleagues, so this highlights the importance of multidisciplinary care. While endoscopic dilation is an option for short strictures, anastomotic strictures, or patients who've had a long interval since their initial surgery, stricturoplasty and resection are also very good options that should be discussed with the colorectal surgeons. I'm going to skip through this for the sake of time, but this is actually a great algorithm that's on this website through the ECHO website. And basically the point is, if you have a patient who has obstructed symptoms, the first fork in the road is, are there inflammatory strictures or is it a fibrostenotic stricture? If it's inflammatory, treat. If it's fibrostenotic, identify which modality, stricturoplasty, resection, or endoluminal dilation would be the most appropriate. So to sum up, strictures that are most amenable for dilation are the 3 S's. They're short, they're straight, and they're safe. You do want to recommend surgical resection for patients who have severe endoscopic disease, for example, deep ulcers or I4 disease. And it is important to start treatment either after your dilation, if they have I2 disease after an anastomotic stricture, or if they have predominantly an inflammatory stricture, or post-operatively, because these do represent higher risk patients. And with that, I'll stop.